Ladies and gentlemen, welcome to today's Guidehouse webinar, 2025 Healthcare Outlook, How a New Administration Will Accelerate Change in the Year Ahead. Portions of this video are recorded. You can use the Q&A box to submit your questions at any time. Now let's get started. It is my pleasure to introduce you to David Burik, partner at Guidehouse, who will guide us through today's discussion. David?
Thank you, Linda, and welcome all to our discussion today. We're very excited about it and glad you joined. Just to kick it off, I would ask my colleagues for some biographical sketch so everyone can get to know their backgrounds a bit first. So, Mr. Johnson?
Sure. I'm David Johnson, the CEO of Foresight Health, which is a boutique healthcare media and advisory company. I have a really strange background: English literature, Peace Corps volunteer, public policy degree, investment banking, and I rely on all of those to try to understand this nuanced, complex healthcare world that we all operate in.
And Paul?
Great. This is a strange combination, as you'll soon find out, but Paul Kusserow. I'm the former CEO and chairman of Amedisys, the largest home health company in the country, and come from an academic background in religion and philosophy via McKinsey, via National Geographic to Tenet Healthcare, Humana, then Amedisys, and I'm presently running one of the largest women's healthcare companies in the country right now, Unified Women's Health.
Thank you. And you combined resources and produced your book, which came out in November. And the central premise of that book is that healthcare will change more in the next 10 years than it has in the last 100 years. And I think that prediction was made with less than 100% confidence that the new administration was going to come in and bring in the January and February that it has. So your prediction's looking pretty strong right now. But as my colleagues and clients started to talk about elements of the book and some of the ideas in it, we formulated there were three areas that we were very interested in continuing the conversation with you about. So the three areas, there's a lot of discussion about the proportion of healthcare which is quote unquote administrative, and the administrative burden that healthcare has, and it seems to increase with technology, not decrease with technology. And so as you look ahead, are there administrative areas that you look for rapid change, which are expedited or facilitated by the administration? And then the same question around technology and the effect that technology has on how we all do our work. So how do the people in healthcare do their work? Will technology expedite it materially in the next couple of years? And then finally, there's a lot of discussion about patients becoming consumers and healthcare becoming more of a consumer experience and how that happens. And that's predicted in the book. And will that be expedited by what you see coming out of the administration? So that's the ground we're going to cover. Let's start with administration. There's a lot of examples that you raised of talking about how there's a lot of stuff that is not direct patient to caregiver. And what's your prognosis for how that may change rapidly in the future? So who's the administrator in the group here? Paul, you're running things.
Well, yeah, I'll take a first crack at it. So that's a good question. I think from an administrative perspective, the reason why there's a lot of administration in healthcare is our system is so complicated. And as we start our book from a historical perspective, which is 100 years ago, there was a man called Wexler who basically produced a
Flexner.
report. Yes,
Flexner.
I'm sorry, the Flexner report, who produced this incredible report for the Carnegie Foundation in about 1910. And he basically created what we're dealing with today that really hasn't changed. And the Flexner report basically set up what we're dealing with today, which is hospital-centric, academic-driven, doctor-driven, acute care focused, which at that time it actually turned out we became the best healthcare system in the world. But what we've seen is the nature of healthcare, the nature of health with our country has changed considerably. We're no longer acutely sick. 90% of the illnesses out there are chronically ill. We don't need hospitals as much as we used to. They're the highest place for cost. And then what we've had, because of the increasing complexity of this with payers joining, we have a very disjointed system that requires various handoffs from a clinical perspective as well as a financial perspective. And that has just created enormous cost in the system, enormous fragmentation, which has produced suboptimal care and also very expensive care. So the question with the administration is, what are they going to do about that? And what we propose is to have better coordinated care, to use coordinated care, and to have that coordinated care run through the continuum, also to look at whole health versus just clinical health. So bring in not only clinical care, but behavioral care, activities of daily living, social determinants, which we see in other countries are much better addressed. But if we're going to have to change towards whole health, continuous care, and less time in hospitals, less time people crashing. Quote, I'm not quoting exactly, but we have in the book is in the U.S., we save people from drowning, but we can't teach them how to swim. And I think that's also something we really need to do. We need to teach people how to consume health. We need to allow the strength of consumerism to really start to play hard here, which the U.S., they're the best consumers in the world, but in healthcare, they're the worst because it's almost impossible to figure out. So I think the idea of value-based care, utilizing technology to string across the continuum and to allow consumers to understand what they're buying and what they're paying for it is quite extraordinary. And one of the reasons I think we're hitting the breaking point, and Dave was one of the inventors of this, the affordability index, we're at a breaking point now with the U.S. consumer and the U.S. family, where we're approaching or have surpassed 30% of their take-home pay is now wasted on healthcare. They don't know what they're buying, or insurance. They don't really understand what the value is. So I'll turn it over to Dave, who clearly has done some really fine work in this space.
And Dave, could I filter it a little bit in terms of, as Paul described, the advantages and the need to be more holistic, and I guess conquering all the problems of interoperability that we enjoy. But we have high administrative expenses in a fragmented world. So how do we achieve the vision that Paul described with administrative costs actually going down?
Yeah, let me first, David, just give the audience a sense of the magnitude of the administrative cost burden that we're talking about. We generally discuss this in percentage terms, and most believe, if you look at the studies, that healthcare administration constitutes 25 to 30% of total expenditure. If you apply that to a $5 trillion total expenditure on healthcare, we end up with a number in and around $1.5 trillion for healthcare administration. That size is bigger than the biggest non-healthcare industry in the country, which is banking. So that's what we're talking about, order of magnitude. Now, Paul got into some of how we got there. Let me amplify a little bit. Going all the way back to the Flexner report, the American Medical Association has insisted on two provisions for American healthcare, invaluable, or whatever that word is. Anyway, two provisions for American healthcare. They are fee-for-service payment and the absolute independence of consumers to choose the physician with whom they want to work. When you add to that third-party payment, which came about almost by accident because of wage and price controls after World War II, we have created a system unique in the world in terms of its ability to not organize and manage costs. That's the fragmented element that Paul was referring to. David, you just referred to it as well. So you started off by asking the question, how is tech going to solve this? And Consulting 101, and Paul is an old McKinsey guy, is you can't automate a broken system. So fix the system before automating it. So we've automated a bunch of broken systems, and for the most part, most of the administrative cost is a hot potato back and forth, payers and providers, over who's going to pay for what. And it's expensive. Nobody wants the hot potato, and that's part of the reason the administrative costs are so high. So we're not fundamentally going to change the way we deliver care until we change the way we pay for it. The good news here is that the payment models are evolving toward full risk contracting, bundles on the episodic care side, and then capitation on the population health side. So as the payment models evolve and the tech supports it, we can begin to have a more rational relationship between administrative costs, which should be far, far less, probably as much as 20% of what they currently are, and the actual delivery of care based on value, outcomes, consumer experience, those types of things.
And I think that the other thing that's important is to think why do we think we're at a tipping point? Well, clearly this new administration sees there's tremendous waste there, and they're targeting extremely large numbers. I think they're going to. I've talked to some people who are heading in to the administration, and it seems like they're going to be focusing on pricing parity, 340B and PBMs. I think, and that's a very good place to start. If you add all those numbers up, I think that's a very good place. But if you follow what Dave is saying, the really what needs to be done is there needs to be, again, true transparency, true understanding of the value of what people are buying, and currently people don't understand that at all. Again, if you go back to any U.S. household and say 30% of your take home is fundamentally allocated to healthcare, they would have no clue that that's the percentage. And secondly, it would be very difficult for them to justify the value of which they're getting. So again, it's transparency, and both hospitals, both sides, hospitals, the largest provider, and insurers benefit from this obscurity and ability to allow consumers into this. So I think that's one of the key things. Will transparency really start to exist? And I think another place to play, as you said, as Dave was saying, when we look at all the administrative costs, you look at revenue cycle management, RCM, that's hundreds of billions of dollars, approaching $1 trillion in terms of a business. That's just for paying people. And to have that absurdity in there just to get paid and fighting over payments, that's where a lot of the waste is. And I think technology can step in there as long as there's transparency and hospitals aren't fighting, to reveal what their true pricing is, and payers are understanding that they can't hide in obscurity in terms of, prior auths and care denials, that sort of thing. It's become a game, and
we're in an industry that got its last boost in technology through the implementation of something called meaningful use, and we all kind of lived through that, and now when we begin to understand artificial intelligence and technology as it is today, it's challenging to see where it's going to have its impact first. And the thesis of this is we're going to have more change. I think a lot of people here think that a lot of that change is facilitated by tech enablement. But then the question becomes, in your work and in your conversations, are you seeing specific areas where the technology is really going to have a profound impact in the short term?
Dave, you want to? I mean, we did an example in the book about how this how technology is driving this from an administrative from a clinical perspective. I think it's going to start clinically. You know, again, I'm running this company that we are doing value-based, risk-based contracts for Medicaid in maternity episodes. And we're using a lot of these methodologies to be able to drive down the cost of care, get better outcomes for, you know, moms with kids who really, you know, who have significant issues for unhealthy births. And so we're using that from a clinical perspective, but then we're applying it from a financial perspective by taking full risk on these people. And thus far, the results are good. I think more and more care coordination through utilizing technology to tie these things together, and then getting people out there, particularly providers, to take risk, I think is going to be that's going to be the straw that breaks the camel's back. I think it's going to start on the clinical side. And Dave, on the administrative side, I don't know what, maybe you could comment on some of your ideas there.
Well, I guess the way I attack this, David Burik, is Paul and I believe the disruptive innovation that's going to bring down the castle, bring down the healthcare industrial complex, largest industrial complex ever created by human beings for the largest industry ever created by human beings, is something we call 3D WPH, democratized and decentralized distribution. That's the 3D part of whole person health. And that's got two elements. The first is care redesign. So going from fragmented crisis care to whole person health. And whenever we've done that, there's been remarkable improvement in outcomes and customer experience. Just look at the Veterans Administration and what they've been able to accomplish. And then the second part is care migration, which is the shifting of care from high-cost centralized facilities, think hospitals, into clinics, into ambulatory facilities, into the home, into the community, into video-based care modalities. And that has enormous potential both to reduce costs and improve outcomes and increase accessibility. So technology's role in that is to, one, facilitate all of this. We do need transparency to make much better value judgments. But the other thing, and I think this is lost on most healthcare analysts, is that we are getting an increasing ability to identify illness far earlier in pre-disease stages, 3-4 years in advance of when disease manifests, through biometric screens of the blood or scans or the breath or signaling from devices, a whole host of things, and then using artificial intelligence to look for small changes, patterns, and then to correlate with the onset of chronic disease. And we are not very far away from being able to tell someone, if you do nothing different, you will have Alzheimer's in 4 years, or a certain type of heart disease, or a certain type of cancer. Now, one interesting thing with the new Trump administration, it looks like Robert F. Kennedy Jr. is going to be confirmed as HHS Secretary. And his agenda is the MAHA agenda, Make America Healthy Again. So one of the things we need to do, and Paul mentioned this earlier when he said, you know, as a system, we're great at rescuing people when they're drowning, but we don't teach them how to swim, is we envision a major shift in resources toward prevention, care management, health promotion, absolutely consistent with the MAHA agenda. Tech can really support that. We all know we should sleep more, eat better, exercise more, have good relationships. But now we have numerous devices inexpensively that can provide real-time information to make smarter choices. And to the extent the government and the external marketplace begin to reward this type of behavior, we could see a very dramatic swing in resource allocation. And we wanted to call the book Gradually Then Suddenly. And I think we're a lot closer to the suddenly stage than most people in healthcare realize.
Yeah, for those people who love Hemingway, that's what we thought. And I think that part of the interesting thing here that you brought up, David, is the issue. I think the blockage here is going to be actually in the place where I think the Trump people least expect it. It's going to be in the halls of Congress, and it's going to be at CMS itself. I can't tell you how many times I've gone to call on a congressman and talk about home health. And we did a lot of lobbying, pushing for home health, which is a fraction of the cost of a trip to the hospital, of an unnecessary trip to the hospital. And literally had a wonderful meeting, and then they say, okay, let's close the door. And they look at you and they say, are you serious? The largest employer in my district is a hospital. And if they turn against me, I'm not going to be sitting in this seat anymore. And then you've got the tremendous lobbying functions you've got of the hospital association plus the physicians there. Remember, over 50% of the physicians now are employed by hospitals. So what you've got is a whole system that's feeding into this voracious black hole of cost, which is hospitals. And so I think to undo that and to provide alternative care outside the hospital, particularly that's what's the most effective for the chronically ill. For acute care, hospitals are what you need, and there's plenty of acute care cases. But for the chronically ill, it's very frequent touch, low acuity, but a lot of monitoring. That's the way you get really good results with the chronically ill. And as we point out in our demographic section of the book, the fastest growing three sections of our society are those people that are 65 plus. So you're seeing tremendous graying of America, and who are becoming chronically ill. The onset of chronic disease is about at 65. So you've got enormous needs. And if we keep throwing people into the hospital, the acceleration on healthcare inflation is going to be extraordinary. And that's the big issue, that they have to come to some understanding that you can't use these, hospitals as your go-to. If you do that, the expenses are going to be incredibly complex and higher. We saw, for example, in my company, we saw healthcare inflation on benefits, and I checked out with other companies between 8 and 9%, and we were able to give people raises at 2 to 3%, and this is compounding each year. So eventually, as that increase goes beyond 30% and starts eating more and more of the American pocketbook, people are just going to say stop, and there's going to be a revolution, and we're getting close to that.
Let's talk about consumers as we start to wind down here for a moment.
Sure.
So we're learning how to be healthcare consumers, and because it used to be go to your doctor, trust your doctor, but then of course most people didn't have a doctor, and then we saw the rise and fall of retail medicine, and the hope of being linked into systems and whatnot. But do you see, is there a catalyst, either regulated or consumer driven, that you think could make 50% of Americans become knowledgeable, effective consumers for healthcare over the course of the next 3 years? Is there a magic bullet that will convert patients into consumers?
Yeah. Well, I would say, David, maybe healthcare's biggest flaw is that the industry writ large does not see a human being at the end of the transaction. It sees a bill, it sees a diagnostic, It sees a treatment, maybe it sees a doctor. It doesn't see a human being. It's the only people-centric industry I know of where the customer and the consumer are not one and the same. And because the American consumer is having to pick up more freight, combined with much greater transparency tools and with the force of regulation behind them, we are now putting individual consumers in the position of making better decisions. And maybe more importantly, we're putting self-insured employers, we're giving them the tools to unleash their employees on the marketplace in ways that they can arrange tailored services that solve their health and healthcare jobs to be done. And that's all happening in real time. 10 years ago, when I founded Foresight Health, I thought the industry could change from the inside out. Obamacare was new. Lots of nonprofit organizations saying the right things. There were all kinds of new payment models, so on and so forth. But 10 years forward, the industry has proven beyond a doubt that it is just, addicted to the fee-for-service, administrative services only contracting way of doing things. And two aphorisms, when you're in a ditch, first thing to do is stop digging. And then the Einstein quote, which is doing the same thing over and over again and expecting different results, is a recipe for insanity. So continuing to do things as we're doing them just isn't going to happen. Now, there are a couple other things I just want to highlight at the sort of state level. Most self-insured employers are registered in Delaware. That makes them exempt from federal regulation on benefits, but they do have a fiduciary responsibility to use the funds that they dedicate to healthcare for the benefit of their employees. And there are now several lawsuits where employees are suing their employers because they are not getting them adequate pricing. Those cases are going to get decided this year. And if there's a fiduciary responsibility, a clear fiduciary responsibility placed on self-insured employers, that will change supply-demand dynamics in a fundamental way. Also, in Indiana, there are two pieces of legislation. One is limiting the amount that health systems can overcharge for 340B programs. And the other is saying that if a nonprofit charges more than 200% of Medicare, it will lose its tax-exempt status. So you can imagine if these actually become law, and the new governor of Indiana is pushing these, what a chilling effect they could have on sort of the current payment dynamics. So there's all kinds of things going on. And I'll just end this by saying I do believe consumers can change the world. They have so many other industries. The industry has entered into a period of disequilibrium where small changes can have disproportionate impact, transformational in some cases, catastrophic to existing models, and throw on top of that all the activity of the Trump administration. So we're in a period of time right now, unprecedented in healthcare, where the roiling underneath the surface, the roiling underneath the surface is about to explode volcano-like. And it's going to be messy, and there'll be all sorts of unintended consequences. But when the dust settles, the result will be a more value-based system that services the needs, health and healthcare needs of the American people far better than it does today.
And I'm going to
ask a final question to both of you. Love a
Sure.
Quick 30-second answer.
Please.
So there's a lot. This is all about change. We've vividly seen how that change can be accelerated. So the question is, what is the best piece of advice you can give to organizations and major players in the healthcare scene today? They're looking at volatility, they're looking at uncertainty, and these are organizations that really crave stability. So their first instincts, maybe their fiduciary responsibility, is try to defend and protect, but yet they also have a mission responsibility to say, okay, if the market is moving, how do I more fully participate in that market movement. So stable organizations looking at volatility. Please.
Yeah, I would say that my advice to organizations is, and remember, 70% of the commercial, the employer-based commercial service is self-insured. So I think a lot of the change is going to be when the employers are getting so much pressure from their employees that they're going to have to look at alternatives. I think the alternatives that we've been focusing on and where we've seen the best results: primary care, high-touch primary care, and value-based care, where the providers can really participate in the continuous care of those employees. So I think a lot of it will occur there. And then again, I think you're seeing some of the more interesting changes going on in Medicare Advantage. So I think you'll continue to see value-based care pushed through that area. So I think value-based care, focus on primary care. As you saw, there was a piece in our book that talked about Portugal and how primary care had driven down costs and produced better outcomes. And so I think that's the answer people ought to be looking at, and those two answers.
And I'll be quick, David. I'll be quick, David. Number one, acknowledge the system is broken. Number two, acknowledge and, I guess, number two, acknowledge that exponential change is coming. And number three, in order to remain relevant in the marketplace, status quo providers, insurance companies need to embrace value and consumerism. There's salvation in value.
So, David, Paul, thank you so much for sharing some time with us. Thanks to the audience for being part of this. And you can put your questions in the chat. If you're interested in more about the Center for Health Insights, there's a link in your console. Just do it. And have a great day. Thank you very much.